Are you a full-arch dentist feeling the squeeze? It's that constant pressure from the dentist down the street who's always slashing prices. It feels like our incredible, life-changing, full-arch implant work is getting dragged into a race to the bottom. We're up against heavy competition, the constant threat of commoditization, and this pervasive idea that the only way to do more is to charge less. It's exhausting, and frankly, it devalues the incredible skill and care that we provide. So I want you to consider something that might sound a bit radical, maybe even impossible at first. What if you could break free from that downward fee spiral and not only do more full arch cases, but do so while strategically increasing your fees? Imagine that for a second, significantly boosting your case acceptance without discounts, without racing to the bottom or playing the cheap arch game. I know it goes against everything we're usually told, which is precisely why it's such a powerful shift. This isn't about slimy sales tricks or aggressive upselling. It's about understanding the psychology of how we as consumers perceive price, and then ethically applying proven strategic pricing principles that are used all around us to our full arch implant fees. My name is Dr. Michael Ling, and I spent years in my own practice navigating these same frustrations with full arch cases. The fee pressures, the patient indecision, believing that the only way to do more full arch cases was to offer discounts and lower my fees. But after diving deep into strategic pricing and how consumers make fee decisions, everything changed. We started doing more of the cases we loved. Our practice thrived, not by cutting and discounting, but by clarifying and confidently pricing our implant fees. I've since had the privilege of guiding hundreds of colleagues to achieve this same transformation, more cases and higher fees and happier patients. Today, I'm going to lay out exactly how the popcorn effect and the double anchor strategy can revolutionize your approach to how you price your full arch implant options. We're going to look at how to make your preferred treatment options the most compelling, most logical choice for your patients so they feel great about their decision and you feel great about the dentistry you're providing and the fees that you're commanding. Consider the movie theater popcorn pricing model. Most theaters don't have any strategy behind their pricing. Small is $7, medium is $8, and large is $9. These all feel like okay value. But we know from human psychology that consumers don't like to be forced to make hard decisions. They don't want to stand there in line, staring up at the menu board, trying to do the math in their head and debating what size popcorn is the best value. If you wanted to sell more medium popcorn, the novice theater owner might be tempted to lower the price of the medium to make it more attractive. And while the strategy will probably work, it has the nasty side effect of reducing your profit. So what could the theater owner do instead? Well, they could implement strategic pricing and raise the price of both the small and the large popcorn to make the medium feel like a much better deal and the obvious choice. The idea is that with this strategic pricing, the customer standing in line at the concession stand, brain on autopilot, will think to themselves, the large is really expensive. Wow, I can't believe popcorn costs $12 these days. But the medium is only $8, which sounds not too bad. And it's only 50 cents more than the small for way more popcorn. So obviously I'm going with the medium. This strategy leverages two powerful psychological principles, anchoring and contrast. The anchoring principle says that the first price a patient sees, or the anchor, sets their expectation. And by contrasting other options against this anchor, we can make our preferred solution feel like the obvious best value. In the previous example, we used strategic pricing to sell more medium popcorns. But what if we wanted to sell more larges? Well, it's simple. Just add another option that acts as an anchor to the large popcorn. How about an extra large option that's even more expensive than the large? The popcorn effect is a simple example to demonstrate the power of strategic pricing. We can influence someone's perception of value by first introducing a more expensive option. You know you're using the anchoring principle properly if your customer thinks in their mind that second option has almost as much popcorn as the first option and it's way less expensive. Of course, I'm going to go with that option. But using a more expensive option to make your preferred option feel like a better value is really taking advantage of only half of the effect, because you can also double anchor. The double anchor effect means adding a second anchor, what I call a reverse anchor. to make this anchoring effect even more powerful. Now your preferred treatment option is bracketed on either side by two other options. One anchor is more expensive and the reverse anchor is less. So here's how your anchors should work together to guide the customer to the preferred option in the middle. The reverse anchor should be way less desirable than your preferred option, but only a little bit less expensive. And then the anchor should be only a little bit better, but way more expensive. So let's revisit the popcorn principle again. Remember the original pricing model that didn't use any strategy. Small as $7, medium $8, and large as $9. And again, just to review, if you wanted to sell more mediums, the temptation would be to just reduce the price. And that would probably work, but you're also going to make less money. But if we want to apply what we've just learned so far about strategic pricing, we could sell more mediums by increasing the prices of both the anchor and the reverse anchor, while also contrasting how desirable each size is. And in this case, we could adjust how much popcorn comes in each size. So the purpose of the anchor is to get the customer to think, the large popcorn is only barely bigger than the medium but costs $4 more. So obviously the medium is the smarter choice. And then the reverse anchor gets them to think, the medium has way more popcorn than the small, but it's only 50 cents more. This double anchor effect guides the patient towards your preferred option, the medium, making it feel like the obvious choice and best value. And because you've increased the price of the anchor and the double anchor, no matter which option the customer chooses, you win. Our goal in applying what we know about strategic pricing and the popcorn effect to full arch implants is to make your preferred solution the most logical and valuable choice for the patient without having to discount. And we do this in 2 steps. First, you have to come up with one clear treatment plan that you feel is best for the patient based on what you know about their condition, their prognosis, and their priorities. This strategy does not work if you just give the patient a menu of options that all seem equally good. And then second, use an anchor and a reverse anchor to guide your patient to that choice. Let's look at an all-on-4 example. A typical fee structure might be FP1 at $35,000, all-on-4 at $25,000, and then an overdenture at $10,000. The problem with this approach to fees is they all seem pretty good. It's like the small popcorn for $7, the medium for $8, and the large for $9. The patient is just left to choose between good, better, and best. The fees just exist, they don't help you at all, and don't influence the patient at all. So here's how we would modify our fees to take advantage of the popcorn effect. First, increase the fee for the anchor, the FP1, from $35,000 to $50,000. The patient should feel like the all-on-4 is 90% as good as the FP1, but only half the cost. Then we increase the fee for the reverse anchor, the overdenture, from $10,000 to $20,000. Now the patient questions why they choose a clearly inferior solution like the overdenture when the superior all-on-4 is only a little bit more. Now remember, we aren't only comparing the price of one option to the other. We can also compare other features that to make our options feel more or less desirable. In the previous examples, we used FP1 as the anchor for our preferred treatment option, the all-on-4. But FP1 isn't the only anchor to use. The anchor can be any option that's more expensive and less desirable than your preferred option. In fact, I rarely use FP1 as my anchor in my office. The most common anchor that I use is the middle one on this screen, the if you don't have enough bone scenario. So let's put everything together by showing you some examples of exactly what I say to patients during consults. But this is the basic framework. Present the anchor first, which is way more expensive but only a little better than your preferred solution, highlighting the pros first and then the cons. And then present the preferred solution, which solves all the downsides of the anchor and now feels like a much better idea. And then lastly, close with a reverse anchor, which is only a little less expensive but way less desirable, highlighting the pros first and then ending with the cons. So here's what it looks like when we're actually talking to patients. Mrs. Jones, there's a few different ways that we can help you get rid of your dentures so you can eat and smile with confidence again. And now I'm going to present the anchor, the FP1, starting with the pros and then ending with the cons. The first way to do it, Mrs. Jones, is that we do a series of implants from cheek to cheek, maybe 6 or 8 implants or so, and then you get some white porcelain teeth that are secured to those implants. And now I've just described in layman's terms what an FP1 is. Now I'm going to highlight the pros. The good side about the great thing about doing it that way, Mrs. Jones, is that it looks fantastic. It'll be rock solid for chewing. You can eat anything you want without hesitation or any restrictions. There's nothing covering the roof of your mouth ever, and you never have to take your teeth out ever again. And now we're going to move on to the downsides. The problem, though, Mrs. Jones, is that you just don't have enough bone for that approach, which doesn't mean that you can't do it. It just means that it's harder. You have to get some bone grafting done first, sometimes 1 or 2 rounds of bone grafting over a period of 6 or 12 months, and then we're ready for the implants. And I can't do that bone grafting for you. I have to send you to see a specialist, which means meeting another doctor. You're probably going to have to wear a denture for a lot of that healing time. And then by the time you pay the specialist fees and you pay me, well, that's when people can easily spend in the $50,000 to $60,000 range just to fix their top teeth. So I've just presented the FP1 as the anchor, giving Mrs. Jones the bad news first, giving Mrs. Jones the good news first, and then the bad news. And now I'm going to move on to the preferred option, which is the all-on-4, which is positioned to solve all the problems of the anchor. So I'll continue with the patient. The other way of doing this, Mrs. Jones, is a more modern approach that uses today's technology and more advanced implants to get you an end result that's virtually the same as the first way. But with this way, you only need 4 implants, not 8. And you do have room for 4, which means you don't need bone grafting. And if you don't need bone grafting, that means you don't have to see the specialist, you don't have to wait for healing, you don't have to wear a denture at all. And because it's far fewer visits, far fewer appointments, far fewer surgeries, and you're only dealing with 1 dentist, not 2, your fee is also less. So instead of paying $50,000 to $60,000, now you're paying in the $25,000 range. So using the anchor gives context and makes the preferred solution feel even more valuable. And then I might close with a reverse anchor. Mrs. Jones, I know you said you don't want teeth that come out of your mouth, but just so you know, there is another way of doing this. You could get a few implants and a snap-in denture. Now the benefit of doing it that way is that you do save a little bit of money. It's not half the cost, but you'll save a few $1,000s because these options cost in the $20,000 range. The downside, though, is I know you hate taking your teeth out at night, and you would still have to keep taking your teeth out at night. And like you already know, these removable teeth can feel bulky, they cover your palate, and they can be difficult to clean and eat with. And then we'll ask a clarifying question. So Mrs. Jones, which of these 3 options feels like it's closest to what you're looking for? And of course, because of the way we framed it, almost everybody is going to pick the middle option, the all-on-4. Let me show you some variations of this anchoring strategy. In the first example, I used FP1 as the anchor. In this example, I'm going to use the if you don't have enough bone scenario as an anchor. And this is the one that I use most commonly in my practice. It's very similar, except we're just using a different anchor. Instead of anchoring the patient to possibly getting an FP1 instead of an all-on-4, we're anchoring them to, if you don't have enough bone, this is what we have to do. If you do have enough bone, then this is the good news. And it goes something like this. Mrs. Jones, there's a few different ways that we can go about helping you get rid of your dentures so you can eat and smile with confidence again. The main factor in deciding which way you go is how much bone you have. And I'm a little bit worried in your case because you've been wearing that denture for so long, and we know that the longer you've been wearing a denture, the less bone you have. And if you don't have enough bone, it doesn't mean that you can't do this. It just means it's more difficult, meaning you have to get bone grafting first. Maybe 1 or 2 rounds of bone grafting. I have to send you to see the specialist to do this because I don't do this type of grafting. It might take you 6 or 12 months bone grafting, and then you're ready for me to start working with you. So we're going to be done maybe at 18 months or so. For a lot of that time, you're going to be wearing a regular denture, just like you have now, and maybe even a little looser fitting than the one you have now. And then by the time you pay the specialist fees and you pay me, that's when people can easily spend in the $50,000 to $60,000 to $70,000 range. And then we pause and let that sink in because we want the patient to really think about what we just said. This is the anchor that sets the context and the contrast for the rest of the conversation. The good news, Mrs. Jones, is that if you do have enough bone, then you're ready to go as you are, which means you wouldn't need any bone grafting, which means you can skip the specialist, you never have to wear a denture, you're ready to go just the way you are right now, you can have your teeth by next week, and because you're only dealing with 1 dentist and not 2, With far fewer appointments and far fewer surgeries, your cost is also far less as well. Now you're paying in the $25,000 range instead of the $50,000 to $60,000 range. Okay, and then the rest of the consult is the same with reverse anchor. We're diving deep because I don't want to hold anything back, and I want you to see all the variations of how this principle can work. Because there's another anchor that you can use. The first one we use is the FP1. The second we use is the if you don't have enough bone scenario. The third anchor that we sometimes use is contrasting the all-on-4 method with what I call the old way, which is a delayed or staged approach. So I might say something like, Mrs. Jones, there's a few ways that we can go about helping you get rid of your denture so that you can eat and smile with confidence again. The first way is a bit of an older way, and this is how most dentists still do it today. The good news about this approach is that you do get teeth that look super nice, they feel really natural, they're rock solid in your mouth, so you can eat anything you want without hesitating, no restrictions, there's nothing covering your palate, and you never have to take your teeth out. The problem though is that it can take a long time. The way that most dentists do this is they do it in stages. First they take out your teeth and let that heal for a few months, and then they put the implants in and they let that heal for a few months. And then at the end, they connect your implants, your new teeth to those implants. And for a lot of that time, you'd have to wear a loose denture while everything heals. And on top of that, you don't have enough bone for all those implants. So before you even start, you have to go through the bone grafting process, which might take another 6 or 12 months. And then by the time you pay all those doctors who are involved for all those appointments over a period of 12 or 18 months, well, that's when people can easily spend in the $50,000 to $60,000 range. That sets our anchor. It's way more expensive and less desirable than our preferred solution. The good news is, Mrs. Jones, is that dentistry's come a long way. What we found with our patients is that they don't want to go through bone grafting. They don't want to wait 12 or 18 or 24 months to get their final teeth, and they don't want to wear a denture even for a single day. So that's why we have more modern approaches in our office that get around all those problems. The end result is the same. You still get beautiful teeth that are rock solid, nothing covering your palate, and never have to be removed. But with our more modern techniques and our advanced implants, we condense everything down into a single day. So you can literally walk into our office with your teeth the way they are now, and then a few hours later walk out with brand new teeth that look amazing, they feel rock solid in your mouth, and you never have to take them out. Okay? So by establishing the old way first, and all the downsides of the old way, it makes our preferred solution, the new way, the all-on-4, feel even more valuable and like the logical option. Let's dive even deeper, because the previous examples, the all-on-4 was our preferred solution. But what if the clinical situation calls for an FP1, not an all-on-4? So now the FP1 is our preferred solution. How do we guide our patients to the FP1? Well, it's simple. We just add another option on top of the FP1 that's even more expensive and less desirable. In this case, you could use something like an FP1 with major bone grafting. Imagine a scenario where if we're going to do implants on the molar sites, we're going to need bilateral sinus lifts and maybe even some horizontal expansion on the anterior because we're not able to do plasty to get down to a wider base. So before presenting our FP1 as a preferred solution, we'd present the FP1 with a major graft, highlighting the downsides, the same as we did before: major grafting, the possibility of visiting a specialist, the healing time, the need to wear a denture during healing, and then of course the increased cost. And by doing that first, then when we present our FP1, even though it comes with a very high fee, it still feels like a much better value. And lastly, one more example, because sometimes we meet patients where we feel like an overdenture is the preferred solution, not a fixed solution. If overdenture is our preferred solution, how do we guide our patient to it? Same as always, we first introduce another option that's more expensive and less desirable. In this case, you might use all-on-4 as the anchor. And it would go something like this. Mrs. Jones, there's a few different ways that we can help you get a more comfortable denture so that you can eat and smile with confidence again. The first way is a complete overhaul. It would mean getting you teeth that are locked in your mouth permanently. It feels super strong, you can eat anything you want, and you never have to take your teeth out. The downside, though, is that it's a more invasive surgery for you and more work for me. And more work for me means more cost for you. So this type of solution can easily cost in the $35,000 range. Now note that in the previous examples, our all-on-4 is $25,000. In this example, for this patient, I purposely increased the fee of the all-on-4 to make it a stronger anchor. There's no rule that says you have to quote the same fees for the same procedure for every single situation. And then we move on, now back to our patient. Now we're going to present the overdenture as a preferred solution. The other way of doing this, Mrs. Jones, is not to do a full overhaul of your mouth, but just to add a couple of implants to make your denture a little more stable. The downside of doing this is it's not as solid as the first way. It's still removable, you still have to take it out to clean it, and it still moves around a little bit when you eat. The benefit, though, is that might not really matter to you because you told me you actually don't mind taking your teeth out and you like being able to take them out to clean them. So doing it this way means you'd still be able to take your teeth out to clean them, but they'd be strong enough that they're not sliding around every time you talk or try to eat something. And because it's far less surgery, far less work for me, then it's also less expensive for you. Now you're going to spend, instead of the $35,000 range, somewhere in the $20,000 range. And then we're going to present our third option. The third way we can do this, Mrs. Jones, is we can just throw your denture in the garbage and make you a brand new one. The benefit of doing this is that you save a little bit of money. A denture like that will cost you in the range of $12,000. The downside, though, is I'm not sure how much better it's going to be than the denture you already have. So, Mrs. Jones, let me ask you, which of these three options feels like it's closest to what you're hoping for? Now note that $12,000 is a crazy fee for a complete lower denture, but I purposely increased that fee for Mrs. Jones to drive home the point that the middle option is the best value for her and the obvious choice. What patient would ever choose a regular denture for $12,000 that's barely better than the denture they already have, when they could spend just a little bit more money and get an overdenture, which is going to be way better than their current situation? Now that you've seen how strategic pricing and the popcorn effect can help guide your patients to make decisions you know they and you will both be happy with, let me answer some of the questions I get all the time when I talk to dentists about how to apply these strategies to your own full arch implant fees. First, how far apart should your fees be for your anchor and your reverse anchor? As a rule of thumb, aim for your high anchor to be about twice the cost of your preferred solution, and your reverse anchor should be about 80% of the cost of your preferred solution. So if your all-on-4 is $25,000, your FP1 could be around $50,000, and your overdenture reverse anchor could be around $20,000. The key is for there to be a wide enough spread that it creates a clear distinction of value. Which anchor should you use? Well, remember the rules for choosing an anchor. It should be more expensive and less desirable than your preferred solution. But there are sometimes several options that you can come up with that are both more expensive and less desirable, and they would all work as anchors. So how do you know which one to use? Well, it's a combination of two things. First, once you do this enough times, you'll get into a groove and discover a script that works the best and feels the most natural to you. For me, I tend to use the if you don't have enough bone anchor the most often. I really like this one because it leaves a little bit of mystery and suspense. By the time you've anchored to if you don't have enough bone and all the downsides, the extra surgeries and the cost, and then show them what might be possible if they do have enough bone and don't have to worry about any of that, then the rest of your consult, your patient sitting on edge, eager to find out if they qualify for treatment. It's no longer about us convincing the patient they should do implants. Now it's about letting them know whether or not they qualify. The second factor is which anchor applies most closely to the patient's situation. So if they mention that they were told by another dentist they don't have enough bone, or if they've been wearing a regular denture for years, then the if you don't have enough bone anchor is effective because it hits close to home for them. And if you have a patient that looked into implants at another office and was told they need to see multiple specialists and wear a denture during healing, then using the old way as an anchor will be especially powerful. Now, what if the patient chooses the anchor or the reverse anchor? For example, you've presented your FP1 at $50,000, all-on-4 at $25,000, and your overdenture at $20,000, and the patient chooses the overdenture. Well, that's great. You just got an overdenture case at a fee that's higher than a lot of docs' all-on-4 fee. And what if they choose the FP1, and for whatever reason, you feel like it's just not an appropriate option clinically? then just re-anchor them again. Acknowledge the pros of the FP1, but then highlight the downsides and why you don't think it's a good fit for them. And by guiding the patient from a more expensive option to an alternative that's better for them and half the cost, you've just earned a tremendous amount of trust from that patient. Now, some people ask, isn't this type of manipulation unethical? Well, these types of persuasion techniques can be unethical in the wrong hands and used in the wrong way. Remember, though, that we're guiding the patient not to the most expensive option. We're guiding them to the option that we know will make them the happiest with the lowest chance of long-term regret based on our experience, expertise, and what we know about the patient's history, their condition, their prognosis, and their priorities. And in my opinion, it's even more unethical not to use your experience and expertise for your patient. They came seeking your advice as the expert. They want to know their options, but they also appreciate a clear recommendation, not a fuzzy menu of confusing options that all sound fine. And at some point, you're going to have to make decisions on your patient's behalf anyways, using your experience and expertise. We don't ask our patients how many implants they want, or whether or not they should do pterygoids, or what size multi-units they want. An ethical doctor will always make these kinds of decisions in the best interest of their patient, not in their own best interest. And the same goes for presenting preferred options and acres. And lastly, if you're worried that raising your prices will scare away your patients, then maybe you need better patients. You probably have a marketing problem and a positioning problem, not a pricing problem. And you should check out the other videos on this channel about how to target the right kinds of patients.